Good morning. Good morning, everyone. So my name is Dr. Manish Garg. A brief introduction about myself. Excuse me for my voice today. I'm born and brought up in Mumbai. I did my MBBS from SAIT JSMC and KEMH. I went on to do my MS from BJMC Pune and did my MCH from Nair Hospital. I completed my DNB cardiothoracic surgery, worked at Sion Hospital before moving to Canada, where I did my fellowship in cardiac transplants. I also went on to Australia to did my fellowship in advanced heart surgery and minimally invasive cardiac surgery. Currently, as was I introduced, I'm a consultant at Bombay Hospital, Tunga Hospital, Holy Spirit Hospital, Nama Hospital, and lastly Bhaktivedanta Hospital. So what exactly is CABG? All of you are aware about something called as bypass surgery or CABG. What exactly it is, we'll dive into it shortly. Heart bypass surgery means nothing but creation of a conduit or a bypass around the blocked part of the blood vessel or the coronary blood vessel to restore the blood supply to the heart muscle. It is also known as coronary artery bypass surgery or CABG in short. So this is what exactly it looks like. Either you use a mammary artery to do the blockage bypass, or you use a vein graft to do a bypass surgery. So what do you achieve by doing a cardiac surgery or CABG? You achieve complete revascularization of the myocardium, which has more than 50% of stenosis. It helps in prevention of sudden cardiac death. It increases and improves the quality of life of the patient and alleviates the symptoms. So in today's talk, we are going to cover the following points. What are the basic concepts in CABG? What are the demerits of a conventional on-pump bypass surgery, which we have been practicing since years? What is off-pump CABG or OP-CAB? What are the various terminologies that keep we hearing around, like mid-cabs and T-cabs and P-cabs? What is a mid-cab technique, which is now coming with a big boom? Trials respect mid-cab and the conventional surgery. And lastly, what a short views on the hybrid CABG. So first, let's understand the anatomy of the coronary arteries. So there are three major blood vessels of supplying blood to the heart. One is the left anterior descending artery, the left circumflex artery, and lastly the right coronary artery. So blockages in one of them or all of them leads to stenosis, leads to angina, leads to dyspnea, for which a surgery is indicated. What are the various conduits that we use for bypass surgery? So there are three primary conduits that we use, either an arterial or a venous conduit. If you have to use a venous conduit, it comes from the leg. So either this is the saphenous vein, either from the thigh or from the lower leg. And if you have to use the arterial conduits, they come from two things. One is either from the radial artery from the hand or the internal mammary artery right next to the chest. So what is conventional CABG? In conventional CABG, we open the chest, harvest the conduits, put the patient on heart-lung machine, do the bypass surgery, wean them off the machine, and shift them to the ICU. The positives of the conventional CABG include relief of angina in more than 90% of the patients. 80% of the patients have an angina-free interval of more than 10 years. So there are lower chances of restenosis as compared to an angioplasty or PCI, and less incidence of MACE. MACE is major adverse cardiovascular and cerebrovascular events. All right. But since we do a conventional CABG, which involves use of a heart-lung machine, the patient has to spend 2 to 3 days in the ICU and overall around 7 days in the hospital. It normally takes around 1 to 3 months for a complete recovery of the patient for him to be able to go back to work. There are around 5 to 10% chances of complications, and which can include neurological, acute kidney injury, infection in the form of lung, or bleeding. So the mechanism for most of the side effects for this conventional or on-pump CABG includes the use of cardiopulmonary bypass machine, which creates these microemboli, which can be either from the air or clots or small platelet plugs, which goes into the circulation and hits your brain, hits your kidney. The other thing which this heart-lung machine does is complement activation, which leads to SIRS or systemic inflammatory response syndrome, leading to MODS and ARDS and AKI. This heart-lung machine, yes, we are demonizing it, but for a cardiopulmonary machine, it does has its own side effects. It also causes loss of platelets, leading to activation of coagulation factors, leading to increased need for blood transfusion and its products. And lastly, because of the conventional CABG, the patient has a large wound incision, which definitely prepons to a wound infection, especially in diabetic patients. So what is off-pump CABG? Off-pump CABG is doing the entire bypass surgery without the use of this heart-lung machine. So in off-pump CABG, we use a conduit called as a LIMA, or the left internal mammary artery, which is a very unique conduit in the form because it is resistant to atherosclerosis. So it has a near continuous elastic lamina which keeps on releasing the prostacyclins, the nitric oxide, and the platelet inhibitors. So the long-term patency of this conduit is excellent. It is less muscular as compared to the other arterial conduits like the radial artery or the gastroepiploic artery. And since its origin from the subclavian artery, which is close to the heart, so there is no need for doing a proximal anastomosis for this conduit. If you look at the patency rates of the various conduits over a period of 1 year and 10 years, you can see from this chart, this saphenous vein graft has a patency of around 80 to 90% at the end of 1 year. However, it drops down significantly to less than 50% at the end of 10 years. The same thing for a mammary artery conduit. The patency is more than 98% at the end of 1 year, and the patency is still upwards of 90% at the end of 10 years. So if a patient gets an off-pump CABG with the use of an arterial conduit, primarily a LIMA or a RIMA, that is the left or the right internal mammary, the chances of him surviving more than 10 years are very high. So where exactly are these LIMA and the RIMA? So these are the two major arteries arising from the respective subclavian arteries and either side of the breastbone or the sternum. What we do in CABG is harvest these two arteries. We take a free graft of the RIMA, the one that the arrow is showing, and put it onto the RIMA, make it like a Y conduit, and then wrap it around the entire heart to do the bypass surgery. So this is a small 5-second video demonstrating how we do a Y graft with the LIMA RIMA. So as you can see, that's the left internal mammary, that's the right internal mammary, and that's the Y anastomosis that we have done for the. And this is how post CABG, once all the conduits have been anastomosed to the heart. So that's the left internal mammary artery going to the LAD. That's the diagonal graft. Here is the left internal and the right internal anastomosis together, LIMA, RIMA, Y. And the RIMA goes all the way down to the PDA. All right? And this, as you can see, is being performed on a beating heart or an off-pump CABG. So, why off-pump CABG? Okay, because majority of the side effects of CABG, especially those related to the cardiopulmonary bypass machine, are circumvented when we do an off-pump CABG as compared to a on-pump. There have been numerous trials and RCTs which has shown that off-pump is better as compared to an on-pump CABG. But why do surgeons still prefer on-pump CABG? Because it is technically simple. Doing an off-pump CABG is like operating on a car or doing a servicing of a car when the engine is running. So it's technically more challenging. So not many people do off-pump CABG, but yes, that's the way forward to avoid all the complications. And when you do an aorta-free surgery, especially a LIMA, RIMA, Y, using a total arterial conduit, it has a proven advantage over using a vein graft. So coming to the 21st century, as we are modernizing, more and more people are demanding smaller and smaller incisions. They want to return to the work much earlier rather than waiting for 1 to 3 months after a bypass surgery. They want something that has to be cosmetically appealing with lesser complications and similar outcome as to an off-pump CABG without compromising on the outcomes at all. That gave birth to something called as a minimally invasive CABG, which is nothing but an off-pump CABG which is performed without a full median sternotomy. So rather than having a big scar right in the center of the chest, the entire bypass surgery is performed through small incisions around the chest. So before we delve into it, let's come to the various terminologies that rotate around this minimally invasive CABG. Firstly, we talked about the off-pump CABG or the OP-CAB. Second is the minimally invasive direct CABG, it's also known as the mid-CAB. Third is the port access CABG, which is outdated nowadays and is no longer done, so we'll skip that part. Fourth is the totally endoscopic CABG, or also known as TCAB. And lastly, we'll touch briefly upon the hybrid procedure, which is nothing but a combination of bypass surgery or open heart surgery along with a PTCA or a angioplasty, which is done together simultaneously in the same patient. All right. So the terminologies which qualify for minimally invasive CABGs are either a mid-CAB, a TCAB, or a port access CABG. So what are the indications? Are all patients suitable for doing this minimally invasive CABG? Answer is strict no. There is a restricted group of patients in whom we can perform this surgery in a safe manner. So patients who have a single vessel disease, that is blockage is only one of the blood vessels of the heart, multi-vessel disease with a very high perioperative risk, hybrid procedures, patient who want to opt for the benefits of both worlds. So they want to take the benefits of angioplasty as well as the bypass surgery. We can definitely contemplate doing a hybrid procedures for them. Patients who have already had a CABG in the past and now they have developed blockages again, either the vein graft for use which has blocked over the last 10 years or so, in them, rather than going through the same approach, doing a minimally invasive is much safer and gives a very good results. And lastly, but not the least, patient preference, especially in younger patients, especially we are seeing more and more patients in the 40 to 50 age group undergoing bypass surgery. So they prefer, they don't want a big incision right in the center of the chest. They prefer something which is more cosmetically appealing. So we consider minimally invasive in those set of patients. Coming to mid-CAB or minimally invasive direct CABG, it does not use the cardiopulmonary bypass machine. It has a smaller incision. It is fast emerging as a replacement for the conventional off-pump CABG that we have been doing of late. This started in early 2000s, but has been only gaining popularity of late and usually conducted for Lima to LED grafts. So this is how this incision is performed. As you can see, the head end is towards our chairpersons and the foot is towards me. A 10 centimeter incision is placed just around the nipple on the anterior chest wall on the left side. We use special retractors to harvest the mammary conduits. We use these special stabilizers, which stabilizes a beating heart with the help of a starfish or an octopus. And lastly, the LAD is exposed, or that is the left anterior descending artery, which has a block, is exposed. The mammary artery, as you can see, has been held taut. The LAD is opened and the anastomosis is achieved, and this is what the completed anastomosis looks like. So this mid-CAB is done in a right lateral position with a 15 to 30 degree tilt with a small 5 to 7 centimeter incision in the 4th or the 5th intercostal space. This is primarily done for a blockage in the left anterior descending artery. But if, however, patient has multiple blocks in the other artery, like the circumflex or the right coronary artery, similar small incisions can be taken subxiphoid as well, and the anastomosis can be secured there as well. So this is what a completed CABG looks like in a mid-CAB. If you can see just under the nipple, around 7 centimeter incision with a chest tube hanging out from the left side of the chest. And this is it. There is no big cut. This is what the patient goes with in the ICU and goes home after 3 to 4 days. These are my happy patients from Canada, where I used to do this very frequently. 3 of them who received minimally invasive left anterior thoracotomy bypass surgeries. And as you can see, the scar is barely visible. You would not even come to know this patient has had bypass surgery anytime. So what are the advantages of mid-CAB over the conventional CABG? So it does not involve a full sternotomy, no use of cardiopulmonary bypass. The operating time is much less. Initially, the operating time is much higher when the learning curve is very steep. But once you master the skill, the operating time is much less. It is very effective and with a very small incision. Additionally, since the incision is small, the chances of blood transfusion requirement is very less. Patient is under the anesthesia for a very less period of time. So it's moved out of the intensive care very rapidly. There is less pain and discomfort, and hence it becomes overall cost effective for the patient. Now coming to the other minimal invasive CABG, which is called as a TCAB or a totally endoscopic bypass surgery. Robots have been of late very much in the news. It's been mainly used for urological procedures in India. But however, abroad we have been using robots quite a lot for doing bypass surgeries as well. So it involves use of a high definition 3D endoscope and this machine called a Da Vinci robot. With the help of this 3D endoscope, there is no loss of depth perception, and the magnification can be zoomed up to 15x, all right, or 15 times. This is what the 3D endoscope camera looks like. With the help of this wristed instruments, which gives 6 degrees movement within a minimal space, so there is no loss of touch sensation, which is compensated by using of these fine instruments. This is how a TCAB is performed with the 3 small port-sized holes in the left side of the chest. And as you can see, the instruments are inserted through the 3 holes. The camera goes in the center and the working instruments on either side. We use that to harvest the left internal mammary and the right internal mammary artery. The pericardiotomy is done, the targets are localized, and the anastomosis is either hand-sewn or it's also done, can be done robotically with the help of a U-clip or a staplers. This is the Da Vinci robot which we have been using abroad for doing such cases very routinely. Lastly, touching upon what the hybrid procedure is. Hybrid procedure is nothing but a combination of a bypass surgery and an angioplasty. When do we do this? Okay, it is an option for a non-LED coronary artery disease. So if a patient has a blockage in the left anterior descending coronary artery, because it supplies 60% of the blood to the heart, a bypass surgery is indicated. However, if the blockage is there in the non-LED coronary artery, then a PCI with a drug-eluting stent can be considered as an option. Lima to LED or the arterial conduit is responsible for the majority of the benefit after a bypass surgery. As we saw earlier, the patency of a Lima graft and arterial conduit is more than 90% at the end of 10 years. So definitely that is the preferred modality. And minimally invasive CABG surgery reduces the procedure-related comorbidities. That's why a hybrid procedure can be considered in patients which has multivessel disease, in which you do a Lima to LED, and for the non-LED coronary arteries, you do a drug-eluting stents. So how do we perform this? This can be performed either as a 2-stop hybrid or a 1-stop hybrid. In a 2-stop hybrid procedure, both the PCI and the CABG are performed at 2 different operative suites, and the 2 procedures can be separated by hours, days, or weeks also. Whereas in the 1-stop hybrid procedure, both of them are performed in the same operating suite using a hybrid OR or the operating room, where the PCI as well as the CABG is done simultaneously. What are the advantages of a hybrid procedure? Shorter intubation times, shorter ICU stay, reduces the overall cost. As of now in India, not really the overall cost is reduced because the cardiologists charge their own fees and the surgeon charges their own fees. Return to work is greatly improved. Patient satisfaction scores are much higher, and the patency at the end of the day is similar. So this is what an hybrid OR looks like. As you can see, there is an operating table right in the center with the C-arm of a cath lab and a robotic which is stationed, robotic arms stationed over that table, and a robotic console at the side of the table. So this is a hybrid OR concept in which the bypass as well as the PCI are performed at the same time. Coming to the take-home messages. So Lima-Rima Y is the gold standard for doing an open heart surgery or a bypass surgery. Why? Because the patency rates are much higher. Beating heart surgery is also known as off-pump surgery, also known as OPCAM. Off-pump surgery, which is done in a minimally invasive fashion, is known as a mid-cap surgery. Other mid-cap surgeries are, minimally invasive surgeries are a TCAB or a totally endoscopic surgery. And if we compare off-pump and on-pump, the off-pump scores much higher over a on-pump surgery. And hybrid concept is a promising concept, but the charges at this point of time are way too high for the patient to bear. And for a high-risk patient, definitely a mid-cap should be considered as an option. Thank you, gentlemen. questions?
Hello.
Garg, it was an excellent talk, and as we know that the incidences of IHD are higher now in younger and younger age group. What is the youngest age of the patient that you
That's an excellent question. So there are two subset of patients which I have operated in early 20s. One is a 24-year-old gentleman who had a family history or a genetic predisposition with hyperhomocystinemia, which caused multi-vessel block, and we received a total arterial CABG. And he's now almost 4 years in follow-up, and he's doing phenomenally well. The LV function is very much preserved. Second is a 27-year-old female which was operated for a bypass surgery. Probably she was suffering from arteritis because she had very much osteal lesions in all her arteries. And not only her heart, even her renals were involved with an osteal lesions. So she has also received total arterial, and she is also doing very well.
Thank you, Dr. Manish Garg, sir, for such a wonderful presentation. It's an honor working with you. We are a team in Tunga, where I manage sir's patient. I request our chairpersons, Dr. Preeti Nagarun Mehta and Dr. Krishna Upadhyay, to please felicitate Dr. Manish Garg, sir.